I'll be your host for today's session. Before I introduce our speaker, I'd like to review a few housekeeping items. First, all attendees have been placed on mute. We have found this to be the ideal method to provide clear audio for everyone, but we do want you to submit questions, so please use the questions feature of the webinar technology to submit any questions. All questions will come to me as the host, and at the end of today's presentation, I'll read the questions, and our presenter will do his best to answer them. Second, I want to remind you that we are planning on a 60-minute session today. We may run over depending upon the number of questions. And lastly, I want you to know that SMI will be administering a brief survey following today's session. We appreciate your taking a few minutes to answer that survey. Now it's my pleasure to introduce today's presenter, Mr. Ian Morrison. Ian is an internationally known author, consultant, and futurist, specializing in long-term forecasting and planning with emphasis on healthcare in a changing business environment. Ian combines his research and consulting skills with his incisive Scottish wit to help public and private organizations plan their longer-term future. Ian has written and lectured and consulted for many organizations around the world. He's spoken to a range of audiences, from the boards of Fortune 100 companies to the Chinese Academy of Social Sciences. Ian holds an interdisciplinary PhD in urban studies from the University of British Columbia. He's a past director at the Health Research and Education Trust, a past director at the Center for Health Design, and a director and past chair of the California Healthcare Foundation. Ian's a board member of the Martin Luther King Hospital in Los Angeles, and he also serves as a member of the Stakeholders Advisory Committee of the Program for Health Systems Improvement at Harvard University. Ian recently presented this presentation as the keynote address at the SMI 2016 Fall Forum in Colorado, and we're pleased to have Ian back for this encore presentation via webinar today. Ian, I'll let you take it from here.
Thank you, Dennis. Pleasure to be with everybody. What a difference a week makes, right? I was joking with a group earlier that the benefit of being a futurist is you never have to change your slides, but looks like some of these have to change. So I updated this in light of the events. I'm sorry for being a little late on the trigger here getting on. I was on a call co-presenting with Governor Mike Leavitt and his senior staff to a group that we are, I have this partnership called Strategic Health Perspectives, which has just recently been merged into the Health Intelligence Partners at Leavitt. So we were just briefing some folks on the implication of the election, and I can, without giving away trade secrets, give you a kind of a flavor of what their view and my view is of what it all means. So those of you who, I was with the group in Denver a few weeks ago now, and at that time it was a run-up to the election, so I'm really going to add a little bit of color commentary about what has happened. And my overall theme remains the same: progress and promise. I've been looking ahead at American healthcare for 30 years, and certainly I think it's an exciting time, and has just been amped up in excitement with the recent news, obviously, of Trump administration. So I'm going to cover why I say progress and promise. I'll take us through what I think are 12 big stories about the future, and make some comments about leading change, and hopefully give some perspective to what this might mean for the supply chain. So here's the deal. We have made progress in terms of coverage expansion, and it was done through Obamacare. 20 million Americans got coverage, and I think what was reassuring in the call I just on, that the sophisticated inside Republican policymaking apparatus recognized fully that abandoning coverage for that 20 million isn't something you can do overnight. So there will be a thoughtful process, but make no mistake, we are going to do a kind of a repeal and replace. And the question is, what's it going to look like after all the dust is settled? But what was also clear in this call, and which I, again, agree with 100%, is that payment reform is not going away. In fact, if you look, even the macro legislation passed the Senate 92-8, and my colleagues were just reaffirming that point of view, that all of these component parts are not going away, and indeed Medicare Advantage and Managed Medicaid are likely to grow even faster in a Trump administration as a mega trend than in a Obama administration. And that bundles and value-based payment are not going away in the private sector. So these movements are sort of, I think, independent of the shifts that are taking place towards repeal and replace. The movement away from volume to value, again, is something that Governor Leavitt and other healthcare leaders on the Republican side of the line have greatly encouraged, and my belief is that this will be a centerpiece of policy going forward. And it's reinforced by the fact that in the marketplace, you've got providers themselves who are embracing risk and embracing population health, and we'll talk more about that. The mega trend that is probably unaffected by the election, quite frankly, is the mega trend that was going on even before President Obama was elected, which is the consolidation and integration in the system in terms of more and more health plans and consolidating and health systems consolidating. We'll talk a bit more about that. And the other trend that we often overlook, but is sort of a fact of contemporary American medicine, is the shift to the ambulatory environment. I mean, my wife had knee surgery a couple of weeks ago, or a month ago now, and I dropped her off. Well, I didn't just drop her off. I took her to the appointment at 7 in the morning, but she was back in the house by 10 in the morning. If she had had that knee surgery in my native Scotland when I was young, she'd have been in the hospital for 6 weeks. So we forget that this massive shift to the ambulatory environment has been enabled by technology and encouraged by payment systems. And the other thing we often forget is the progress we've made as a nation with regard to IT infrastructure. We've seen ubiquitous deployment of electronic health records as a result of the stimulus bill and the HITECH Act, which provided money for electronic health records in America. And now virtually every hospital and every doctor has access to those, even though I call it meaningless use. They still have been deployed. The other thing to note is a massive investment in consumer-facing technology, and I live in Menlo Park, California, ground zero of venture capital and all things innovative, one would argue, and there's significant investment being made in consumer-facing health technology. And that brings me to one area where we do need to improve, which is the consumer and provider experience in health. High deductible healthcare has been a pretty blunt instrument, and I think you're going to see more of it, quite honestly, going forward. And I think one of our big challenges is going to be how to engage consumers more intelligently, so that they're not just angry, but they're actually feeling that they're getting value from the healthcare marketplace. And the other point I'd make is that we don't consume health in a vacuum. We consume health, and judge it against other services that we consume, whether it be, airlines or travel reservations or financial services. And increasingly all of those, including all of our interactions with our family and friends, is mediated through our phones. And so increasingly we're going to see that judgment of quality and service being applied to healthcare. Right now, you leave your phone and then you deal with the health system, and it's going back into another century where people are writing on whiteboards in Babylonic cuneiform and faxing things to each other, which is quite medieval. So I'll remind us all that we did see a drop in the uninsured. This isn't a communist plot or made-up data. It's the one reality that Obamacare has delivered on, that the number of people, 20 million Americans, have health insurance as a result of coverage. And I think the new Republican establishment is going to have to recognize and mediate that going forward. And I think they're aware that simply dropping it overnight is not going to happen. The question is, what will be the migration and who's going to pay for it and how? So there are 12 big stories I want to cover very quickly, and hopefully we'll have time for questions at the end. Obviously, the election is top of mind for folk. I do want to say a little bit more about consumers, about consolidation, the role of employers. the hydraulics of healthcare that I call, particularly the prices paid by private purchasers. I want to call out specialty pharma and Medicaid and behavioral health very quickly as issues that are going to get more attention, and spend a little bit of time on the shift from volume to value and how that's manifesting itself with health systems across the country. And if we've got time, a little bit on population health and innovation at scale, which I think is really the solution. If you want to nod off for half an hour, that's what we're really driving towards, is we have to innovate our way out of what is an affordability mess. So let me just speak to the election. I think going in a week ago, people were speculating this would be a blowout for Hillary Clinton. There was some, before the email scandal resurfaced, she was campaigning in Arizona and then lost in a very surprise upset election. It was very similar to Brexit. For those, I'm Scottish, so I had to bring this up. And I was actually over in Scotland before the Brexit vote doing field work playing golf at St Andrews. But anyway, and you'll recall that Scots disproportionately voted to remain in the European Union, as did Londoners and folk in Northern Ireland. It was really only Middle England, and think Middle England is Pennsylvania, Wisconsin, Ohio, a very much similar kind of industrial or deindustrialized part of Britain, and they were the ones who voted against. In fact, Mr. Trump, no accident, was over the day after Brexit, and he was speculating that the Scots took their country back, until my Scottish colleagues pointed out that they actually voted to remain. And I'm proud of my Scottish brethren for reaching new heights in the use of profanity and creative use of the English language in disabusing Mr. Trump that the Scots were in favor of Brexit. But anyway, if you look actually at what happened in the vote, is not dissimilar to what we've seen, as I'll show you in a second, in this recent election. The people, this is the Brexit vote, the people who voted to exit, and remember what this was. This was a vote about the future, and people over 65 aren't going to be in the future very much longer. But anyway, they were the ones who disproportionately voted to leave the European Union, and in areas that had fewest graduates, were more elderly, more nationalistic, that was the most likely concentration. So Mr. Trump triumphed across the country, a remarkable victory given where the polling had come in beforehand. The blue bits are Democrat, the red bits are Republican. And so, by county, it was a massive victory. I mean, there are quite a lot of people live in the blue bits, which is the reason why the popular vote was actually in favor of Hillary Clinton. But, that's not how we run the country. We run it on the Electoral College. The similarities with Brexit are quite striking. 58% of, if you were white, 58% voted Trump. If you were white without a college degree, it was 67%. If you said you wanted a candidate to bring change, it was 83%. If you lived in a small city or rural, it was 62%. 60% of people in big cities voted for Clinton. 69% of people who said the country is seriously off track voted for Trump. 78% who thought the financial situation was worse. 77% were angry about the federal government. Angry about trade, had a sort of pessimistic view for the future. And unsurprisingly, people who want to deport illegal immigrants and support building a wall disproportionately voted for Mr. Trump. So it reflects, and this is the point Governor Levitt made to the client group an hour ago, a very big shift between one team and the other. And it has to do with attitudes towards government. And my colleague Bob Landon at Harvard has a wonderful series he's doing now with Politico, which I urge you to follow over the next year, that shows basically the differences between Republicans and Democrats, between Clinton voters and Trump voters, and attitudes towards the Affordable Care Act. One group thinks it's going badly, the other group thinks it's going reasonably well. And that spins around how they view government. So amongst voters who say government should play a major role, those voters, Democrats generally, think the ACA has improved the world and is working well. for those who don't believe government should play a bigger role, disproportionately, vastly, see it as working poorly. And that's the grand divide, really. And that explains why we are going to repeal and replace. One team won, and they have a very different view from the other team in terms of what should happen to the ACA. Now, the replace part is going to be more incremental and not as dramatic and not as overnight as you might think, but nevertheless, it's certainly likely to happen. So what will it involve? Well, I think there'll be changes to the ACA. It's certainly not going to be called Obamacare after this. They'll call it Trump Care, and no matter what it is. And you know, you're probably going to see the best indicator is the legislation, the proposed legislation that Speaker Ryan put forward, and if you go read that 30-page manifesto, that will probably be the blueprint for what will make its way through the legislative process. But it involves getting rid of mandates, eliminating the Cadillac tax, probably having risk pools at the state level, more state involvement, but maintaining, hopefully, the coverage one way or another over a period of migration to different forms of coverage, so that the 20 million aren't just thrown out in the street overnight, but certainly a much less regulatory model than the Obama administration has pursued. But the reality is, so that's kind of an overview of the impact of the election. Stay tuned, and you'll see repeal and replace at a theater near you, which will change the marketplace considerably in one level, but will not change the move towards value. So let me dive in here and go through this very quickly on where the consumers are. And Mr. Trump's going to have to deal with this in his administration: rising costs, rising premiums, to the point where the average American family cannot afford the average health insurance premium. Median household income this year will be $56,000. Median PPO policy for a family with health insurance through work is about $18,000. Now, they don't pay that; they pay the $5,000, but their employer's paying $12,800. And any economist will tell you that the total package, the $18,000, is part of compensation. It's not like the money came from Iran or something. This is foregone wages. And so corporate America's big idea of containing costs has been historically to shift more costs to employees. 50% of American workers have a deductible of $1,000 or more, about 29% of a deductible of $2,000 or more, and about 20% of a deductible of $3,000 or more. Now, why that's relevant is that most families at the median income level of 56 grand don't have $3,000. They would have to sell something to pay a $3,000 deductible. And that's why in surveys before the Affordable Care Act this was taken, but the picture was ameliorated a little bit by the Affordable Care Act, people forego care. And so in the case of people in the dark blue who make less than 200% of the federal poverty level but have coverage through work, you know, in the employer-sponsored marketplace, if you're in that category, you know, earning less than what that amounts to 40 grand a year for a family of four, you know, there's almost a 50% chance you're going to forego care because of cost. Now, I hate satisfaction surveys. It's prevalent in the industry. The reason I hate them is they don't change. You know, we've been surveying for the last 30 years in partnership with Harris and Harvard, you know, consumers, employers, hospitals, and doctors. And, you know, when you ask satisfaction surveys, the numbers don't change. I mean, it's like a flat line. And the reason for that is pretty simple. Americans are nice people. If you want to find dissatisfaction, go survey the French. I mean, they're pissed off about everything. Now, occasionally you do see a dip in satisfaction, and that occurred in the last couple of years with satisfaction with my insurance plan. Interestingly, this was not as much for Medicaid recipients, but for people who had employer-sponsored coverage or who, in particular, had exchange coverage. And I think that, ironically, when people say they hate Obamacare, what they're really saying is, I hate health insurance and how it works for me, because only 3% of Americans have coverage through exchanges. It's a tiny sliver. People on Medicaid are pretty happy they've got Medicaid. It's first dollar coverage. But the people who are really unhappy are anyone who's had an increase in out-of-pocket costs. And that sort of reflects more broadly in what we've picked up from consumers, and what I do believe is true, that this is an emotional scale that my colleagues at Harris came up with. And it's this. I like this question a lot. This is literally what the question asks is, how would you describe your feelings about the health care you receive today, including how much you pay for it and the benefits you receive? Please select all that apply. Now, this is going to come to a complete shock. It's a complete shock to men on the phone, but you can have more than one emotion simultaneously. You know, women understand that. Men have a great deal of difficulty with that concept. They have trouble coming up with one emotion at a time, let alone more than one emotion. So it is important to recognize you have more than one emotion, and you get what social science would predict, a normal distribution where you know, the mode is you know, accepting, neutral, resigned, given up, or sort of the middle of the distribution, with a surprisingly large number of people saying they're powerless, depressed, and angry. Now, we had a big sample in this, so we can cut it a lot of different ways. One of the things we found was that 28% of Americans received a balanced bill for care they thought was covered. And if you're in that category, you're much more likely to feel you're powerless, depressed, and angry. Similarly, about 8% of Americans received a bill for hospital services not in network, even though the hospital was in network. And the exchange was even more dramatic in that regard. The most extreme case that I heard about was reported by a TV station in LA. It was a woman who went to a physician. She made sure she had a PPO policy. She wanted choice. She made sure that she was covered, and the doctor was in network. Her issue involved some minor surgical procedure. He said, just go to my surgical center upstairs on the second floor, where he suddenly became out of network. And then he sent her a bill for $18,000. Didn't resolve the issue clinically. She had to go to the hospital to have an inpatient procedure. This time she's all over making sure that the surgeon's in network and the hospital's in network. What she didn't know was the second assistant surgeon and the anesthesiologist were out of network and sent her a bill for combined bills for about 25 grand, which she's still trying to pay off. Now, I think that's ridiculous. And I think it's going to be on health systems to make sure that these kind of financial gotchas don't go forward. So the other thing we found is a group of patients, a group of people in the survey, people who you know, use the health system a lot but have trouble paying for it. And another word for them is patients, right? I mean, anyone who's actually had a hospital admission or has a serious illness likely will be in this category if they make less than about 150 grand a year in household income. And if you're in that category, and these are not the uninsured, they're disproportionately uninsured, but they're not people on Medicaid. Very few Medicaid people have this trouble paying for it. But what we see is that 40% have employer-based health insurance, and if you're in this borderline category, you use it and you have trouble paying for it, you're much more likely to be in the light pink responses of powerless, depressed, and angry. So what do consumers want? Well, in a word, they want cheaper. They want low monthly premiums, low co-payments, access to their current doctors, you know, but they don't need to see every doctor, and they certainly don't need to have access to every hospital. They're willing to trade off choice for cost. But who do they blame? Well, they tend to blame drug companies a lot. They blame the system as a whole. They blame doctors, the Congress. You know, there's a lot of blame to go around. The one thing when we survey, because we survey all the different stakeholders, the one thing that's pretty evident is that really sticks out is that physicians really blame insurance companies, which brings me to consolidation and the fact that we have these massive mergers which are still pending. You know, many of the pundits believe that Anthem and Cigna may not go through because of resistance from the Department of Justice. We'll see what happens with the Trump administration on this. But you know, I was talking to a liberal group of doctors at UCSF a few months ago, and I said to them, you know, the good news for you liberals is we're going to have a single payer system. The bad news is it's United Healthcare. And you know, I think with the Trump administration, that's probably, as we say in Glasgow, half joking, full serious. You're going to see an even bigger role for private insurers going forward. But the consolidation that I think is more meaningful in terms of its effect on prices is not so much the insurance market, but the provider market. And we are seeing systems. You're also seeing programs like you know, Texas Health Resources or Carolinas Health or Baylor Scott and White, who are massive in their region. But you also see these sub-regionals, and you know, I do a lot of board retreats, and I go to a lot of places. I'm currently in you know, in rural Pennsylvania at a retreat for a hospital system, and they dominate their local market. You know, they're $1 to $2 billion systems with 40, 50, 60% market share. And the good news is, if we consolidate and integrate, maybe we can get efficiencies by driving out inappropriate clinical variation and standardizing clinical protocols. The problem to date is that the evidence is weak that that's happened and has made for what one might call better, faster, cheaper. The evidence today is that these systems use pricing power to extract higher prices, and that overwhelms any efficiencies from the consolidation. And we'll yet, you know, I think these systems are going to be held to account over time by public and private purchasers to make sure that they return true value going forward. But there's no question that the consolidation has been significant. We need to be wary of antitrust considerations. 43% of hospitals agree with that statement. A remarkably high 43% agree with the statement. We're talking about hospitals now. In the short term, our efforts towards consolidation are more about bargaining leverage than about quality or value, even if we get there eventually. So that's an interesting and remarkably honest response from hospitals. But the other part of consolidation and integration is really this, and this is, I think, a big story for the supply chain folk, is that more and more of these hospitals are stretching their organizational envelope across the continuum of care, including not just ownership, but exclusive contracts with everything from retail clinics to satellite patient care facilities to behavioral health to urgent care centers. And I think that's a big part of the supply chain challenge going forward, is how do you manage you know, multi-institutional, multi-site care systems. Now, we asked a number of questions, and I put this up here for you to consider at your leisure. I'm not a deep expert on supply chain, but these are some of the trends that we've been tracking. And I don't want to get into the detail here, but I do think that these just sort of reflect, I think, some of the issues in the supply chain world. You could argue about whether there are meaningful trends here or not, but the issue of standardization and selection of purchasing of devices and evidence-based protocols, these are all your daily work and things you're very familiar with, particularly those of you who work in larger systems. What I do think is significant is this last one about outsourcing of supply chain management to outside groups. And you know, you hear stories that as these mega systems get bigger and bigger, they're internalizing more and more of their supply chain work, and some indeed have their own GPOs because they're big enough to get discounts. And so I think that's a factor in terms of your world of supply chain going forward. You're all, I'm sure, familiar with the basic economic fact in American healthcare, the financial lifeblood of American healthcare. The profitability depends on private insurance. And the real question has been over time, are employers going to hang in there in terms of providing health insurance to the employees? I want to contrast the experience of the big guys, the jumbos, which is measured in this survey by Towers, Perrin, Crosby, Stills, Nash and Young, which they do every year for the National Business Group on Health, based on jumbo employers. And the jumbos have actually seen their rate increases. The 2016 number, by the way, we came in at 4%. I'm hearing from some of my friends in that world that they're down around 2%. Now, you contrast that with the experience of small businesses and medium-sized businesses or the individual market. You know, one could argue that part of the thing that did in Secretary Clinton was the juxtaposition of 20%, 30%, 40% rate increases for Obamacare in the very states that, like the state I'm in right now, Pennsylvania, that what became a swing state. And that's why when you ask businesses, is your business performance suffering due to health insurance costs, you see high numbers. Those are the picky folk on the phone will notice the color coding is mislabeled. The 2016 is the higher number, and in the case of our business performance is suffering due to health insurance costs. And it was particularly acute, that number, for smaller businesses. The reason we say employers are going to hang in there, and I think that's an important statement, is this question. You know, I like to put it that the good news is employers are staying providing health insurance. The bad news is employers are staying providing health insurance, and they're going to be in your face, particularly the big guys. And the evidence for this is the red line going up and then down, which basically says this is the percent of employers saying my company is actively exploring ways to get out of providing health insurance to our employees. That peaked around 2013. They took a look at private exchanges and moving from defined benefit to defined contribution, and concluded that they weren't going to save any money, really, for a whole bunch of reasons we could get into, and sort of backed off of that exchange substitution strategy. So what are they doing? Well, I mean, quite frankly, and I'm an advisor to the business group on health, they're flailing around. I mean, they're basically trying everything, and nothing gets an overwhelming endorsement for working extremely well or very well to contain costs. I mean, we give them a laundry list, and there isn't one item that gets over 50% in the top two boxes of approval. They're trying a lot of things, and you could look at the list and pick your favorite intervention. We always find it amusing that wellness comes up on top. We call it faith-based wellness. I mean, there's precious little evidence that you know, investing in wellness in the short run will actually reduce your healthcare costs in this year or next year. What you will do is make people healthier, which is a good thing, and benefit the Medicare program. But that's aside. What's also interesting is the weakness of consumer-directed health plans in this, and I think that's partly because many in our surveys say they've reached the limit of cost shifting to their employees. So one of the things they're very concerned about, and it may be aggravated by the changes with repeal and replace, is the fact that, and I'm sure many of you on the call are familiar with the Dartmouth Atlas, which is the view of the world on the left-hand side of this chart, where you look at per capita spending on Medicare. The great folks at Dartmouth did the math. Dark is expensive, light is cheap. And basically, this is, on the left-hand side, this Medicare spending per capita is a utilization story. You know, aggressive, perhaps some would say larcenous levels of utilization in Florida and Texas and so forth. So utilization is high, and that explains these relatively higher costs per capita. But here's the but. You look at the right-hand side, and the smart Alex at Harvard got the data for self-insured employers and applied the same principles to the same regions, and you see a very different picture. And the reason the picture is different is not that doctors practice differentially when they're dealing with private versus public patients. They do to some extent, but they don't do it systematically. They're many times not even aware when they actually see the patient what their coverage is. But what is true is the price charged, and that varies enormously. And so if you look at hospital prices, In Wisconsin, for example, you're talking 200 or 300% of Medicare, whereas in California, Southern California might be 150%, Northern California might be 250%. So the variation in pricing in the private sector is huge. And that's seen in the AHA data, where what we've seen systematically is as Medicare and Medicaid pay below cost, there's been cost shifting to private payers. And when you survey those private payers, you find a pretty compelling focus on price. Hospital inpatient, specialty pharma, cancer care, hospital outpatient, physician prices. It's not about utilization, it's about price and increasing interest in the price question. And the mother of all examples of pricing is specialty pharma or pharmaceuticals generally, because it isn't just biologicals, it's you know, obscure generics that are being jacked up in price massively, and will get, I think, the wrath. It was going to be the wrath of Hillary Clinton, but it may be the wrath of Donald Trump going forward. Just to illustrate sort of how preposterous some of this stuff is, I put together this slide and I showed it actually to the Kaiser board, Kaiser Permanente's board, and also to the Pacific Business Group on Health board to make a point. I mean, it's not serious, but it's cheaper if you're an employer with a patient who has HEP-C. It would be cheaper for you to send that employee to Egypt for a 3-month luxury vacation, put them up at the Nile Ritz-Carlton, and basically insist they take their spouse, fly them business class, send them on a 10-night luxury spa Nile cruise where you'll be pampered for 10 beautiful days, and you'd still save 30 grand. I mean, that's insane. And it's why in surveys, and in fact we have surveys that came in after this in the last month that show that up to 85% of the American public, including majorities of Republicans, are in favor of price controls or caps on pharmaceuticals. So President-elect Trump will have this drug price issue right on his lap, and it will be interesting to see how he and the Congress respond to it, because it is, you know, of high salience to the American public. Now, one of the things that's happened through the Obama years, and again, the question is, will this be altered, is massive Medicaid. And I just spoke on Tuesday in Washington to the Medicaid Directors of America and pointed out to them that Medicaid is now bigger than France. And the question is, what happens now going forward? There will be efforts, I think, to roll back Medicaid expansion and certainly to make Medicaid look more like it is in Indiana, which has got high cost sharing and so forth, than it does in California. There will be efforts to do that. There will be efforts to block grant it as part of the repeal and replace provisions we'll likely see over the next 12 months. By the way, when you hear block grant, it's code for less money. Nobody's going to give you a block grant with more money. You're going to get more flexibility, but you're not going to get more money. And I think that's a real question going forward. Now, depending on how this reform that comes in the Trump administration plays out, you could, if you're a real, left-wing cynic, say they could get rid of, they could roll back Medicaid coverage without necessarily yanking a card out of people's hands, by simply playing the churn game, namely that 25% of Medicaid recipients churn in a given year, and if you change the eligibility requirements, you could actually see the enrollment go down without actually yanking it away from any individual family at any one time. They'd just not be eligible the following year. But I think the broader question, because Medicaid is not going away in my humble opinion, it covers kids, it covers moms, it covers expansion populations, but most importantly, about over half of the money is in the form of long-term care payments for nursing homes, and it's the default, long-term care policy for the middle class, who spend down their assets and go on Medicaid when they need to be in a nursing home. So I think the big $64,000 question for the country, amongst others, is how do you build a sustainable delivery model for both long-term care and acute care under Medicaid. And here's a chart on the left-hand side from McKinsey. This is why they get the big bucks. I have no idea what it means. But no, actually, there's a serious point here, which is that Medicaid is really something that anybody who's less than 140% of federal poverty level is likely to be exposed to. But there's movement in and out of Medicaid as life changes, right? As you get a job, you lose a job. That's also true of the exchange population, where the churn in California at least was around 40% as life circumstances change. The other thing this chart says very clearly is once you reach 65, you're never going to lose your Medicare until maybe a Republican administration moves the age up, but they won't take it away from anyone. And that, I think, is one of the reasons why Medicare is so incredibly popular and why Mr. Trump promised not to touch it. So it'll be interesting to see what happens with Trump and Ryan. They met just an hour or so ago. Ryan wants to fundamentally change Medicare. Mr. Trump was not biting on that particular one before the election. So, look, part of the conclusion from the call I was just on with the governor is that value is not going away. The shift from volume to value is not going away in a Republican administration. In fact, if anything, it may accelerate, and it may have more private sector tones than government imposed value, but that trend isn't going away. And I think this is why it's important to look at the distribution of strategies that exist amongst hospitals. You see, this is a question we ask hospital leaders and basically say, you have to pick one. On the left-hand side, about 30% of hospitals are saying they have no plans to take risk beyond modest shared savings and pay for performance arrangements. At the other extreme, we have about 6% of hospitals saying we're committed to moving the majority of revenues to fully at risk within 5 years. That's an extreme case. That's the advocates, the Presbyterians, the Intermountain Health, and so forth. A further 9% are also saying we're building an ACO model that is capable of taking risks such as Medicare Advantage or employer direct contracting. And I think that's about right. I think about 20% of systems, or another way to put it, 20% of the beds in America are in a system who's serious about moving and migrating to more of a risk-based model. At the other extreme, there's a 31 no part of it, and then in the middle is probably another 40-50% residual, which is sort of either experimenting with it or is actually quite committed to a clinical integration strategy for contracting, and that's pretty prevalent across the country too. So I don't want to say that you have to be one or the other. I think I know a number of organizations are successful in every one of these strategies and probably will be in their market, but you've got to pick one. You can't just default and hope something happens. And the reason why people are pursuing risk is they hear and see the frustration of employers, the fact that they don't see much value from the plan intermediary in terms of truly getting improved value and performance. And so there is an appetite amongst employers now to consider having a more direct relationship with local hospitals. Now, whether that's just consider it, it's not that they're going to do it, because it depends on the terms of the deal. And quite honestly, I think a lot of hospitals are smoking something when they think they're going to get a good deal from, a self-insured employer like a Disney or a General Electric or a Boeing, because I know these people well, and they're not going to mess around. Talk about supply chain. That's what they know how to do. And to them, health is like any other purchaser, where quality goes up and costs go down. I should say that all these changes in payment reform, and as I say, I do believe they're going to continue even in a Trump administration, including MACRA. This is not being received with rapture and joy by the provider world. They would quite prefer it not to be happening. And when we ask hospitals, and we have the same findings for physicians, which are attitudes towards reimbursement, it's not a majority saying they're loving it. They're reluctant acceptors of it. They're not enthusiastic adopters. And I will say there is a tension between what I call the bundles world and the population health or risk or accountable care world. A bundle is not that alien to a provider system. More bundles is more money. I mean, they understand growth. All a bundle does is put an envelope around the acute care admission to include other components of the care. Now, that's a big screaming deal for supply chain because now you worry about nursing homes and the SNFs and so forth. So it's not trivial. I mean, and I'm supportive of it. I worry a bit about some of the bundles exceeding the total cost of care. And the reason I say that is the wise man, Pat Fry, who ran Sutter for many years, is a friend and has a tendency towards profanity, which I appreciate, said to me that, screw me on the bundle, I'll screw you on the rest, which is a wise statement, which refers to the fact that, you can grind me down on orthopedic surgery procedures because that's where you have bundles and measurement. I'll just charge more for something else you can't do that on. And I think that's actually kind of the way providers, smart providers, honest providers actually play the game. What I do like is when people take risk and are accountable, whether it be population health or risk-bearing models. And the reason I say that is that all of a sudden, once you have the financial risk, you actually care about the frequency and the appropriateness of the services you're delivering. And that's huge. We're also seeing systems that embrace this, whether it be from public or private payers, getting serious about the determinants of health and working up the food chain to recognize the role of those factors in high-cost patients. And so the solution set often looks more like social work than medical care. And I will say that in my travels, there's what I call the mutual disrespect problem, which is that everybody in American healthcare thinks everybody else's job is easy and anyone can do what an insurance company does. And I just don't believe that to be the case. So what we're seeing is across the country, more and more systems hiring Optum, identifying the top 5% of patients that account for 50% of spending, and it's a law of physics. I mean, it's unbelievable when you do this research, and I've done it. I've seen it done in the state of California and nationally and so forth. In any insurance pool, 5% of patients account for 50% of spending. 1% account for 20%, and the bottom 50% utilizers, the healthy folk, use next to nothing. So when you dig underneath that 5%, what you find, first of all, you find Hondas. What's a Honda? Well, I was a Honda. I was denied coverage, or I'm a Honda. I was denied coverage in the individual market in California by Blue Shield before Obamacare saved my bacon. And I got denied in triplicate because they told me I was a Honda, hypertensive, obese, non-compliant, diabetic, alcoholic. None of which is true, but is all directionally correct. And so, that's what you find in every insurance pool, Hondas. You find behavioral health. 20% of Americans have a behavioral health issue. 87% of heavy utilizers have a behavioral health issue. In the elderly end-of-life care, you will see in that 5%. Any insurance pool, anyone in active cancer treatment will be in that 5%. Any insurance pool, any of the frail elderly, if you're talking about Medicare, will be in the 5%. And the solution set, as I say, looks more like social work than medical care. And I will say that anyone in the commercial insurance market, any patient that's prescribed a biological, especially pharma, will automatically be in that top 5% heavy utilizers. So let me just tell a couple of stories, and then I think, Dennis, we might have some time. I've got 2 or 3 other points I want to make at the end here, but let me tell you these 3 stories quickly, which I think illustrate this move towards population health. The first is the story of the truck, and this basically was a young hospitalist who went back to his native Phoenix, trained at UCSF. He went back to a hospital that served, a Latino population. He himself was a Latino kid, and they had a horrible readmission rate at this hospital. And he told the CEO, "I can cut it in half." And how he did it was he took his beaten-up old truck that he liked to drive, and he went back to the neighborhood, and he took the discharge summary, and he gathered the family around, and he spoke to them in Spanish and explained what Grandma had and what she was discharged with in terms of meds and what she should be on now, and gave follow-up numbers and made sure that she got to her appointment schedule. You don't need a board-certified UCSF-trained hospitalist doing this. You could have a kid with a checklist who spoke Spanish, or better yet, a promotory or a friend of the family who's a community health worker doing it. And we're seeing this across the country, whether it be New York or Maryland or California, the use of these community health workers to reach out to vulnerable populations and meet them in their lives. The second story was the story of a refrigerator told to me by Art Gonzalez, who ran Denver Health at the time. And they had done the math and found this number one frequent flyer patient was a Mrs. Johnson, who was a brittle diabetic, who was constantly being readmitted, and who, even though she was in a patient-centered medical home and the entire cast of Grey's Anatomy gathered around her every Friday, and it wasn't until some smart young nurse said to her, "Mrs. Johnson, why don't you take your medications?" And she said, "Well, they have to be refrigerated." And the nurse said, "Well, so?" "Well, I don't have a fridge." So they bought her a fridge, and she never came back. In a good way. I mean, she was fine. So my point is that sometimes you've got to think imaginatively about solving patients' problems. And the final story was a story of the bus told to me by Bernard Tyson, the CEO of Kaiser. Kaiser, as you may know, has gone from, in fact, I ran into the woman who runs Kaiser Medicaid in Washington on Tuesday. Kaiser's gone from 300,000 Medicaid members to over 1 million in the last 2 years. And Kaiser's, feeling it in terms of their emergency rooms and so forth with these new Medicaid eligibles. And in Sacramento, where the bus was, they were having a problem with no-shows at group visits. And Kaiser has an amazing group visit system for diabetics. And, a 10 o'clock appointment with a multidisciplinary team and 20 patients. And there was a big no-show of newly covered Medicaid patients. And the doctors were all getting a wee bit judgy about it, going, "Oh, see, that's what happens when you, deal with Medicaid patients." It turns out that the reason the no-shows were no-showing was the bus didn't get there till 10:30. So Kaiser got on the phone and had the transit authority change the bus schedule. And that's population health. And that's what we're seeing across the country. People doing this math, doing the analysis, using patient registries in the medical home, recognizing that, as my friend David Nash says, with no outcome, no income, it's about what do you do for the population, not what the procedures are. They're going upstream, they're working on their own employees in this regard, and they're leveraging technology and partnering with lots of different people, which may have some implications. And I just close by saying, I think we can solve all of these problems if we innovate. And the problem I see is what I call the scout badge problem. On my travels, I talk to a lot of boards, and you say to CEOs, "Do you have a patient-centered medical home?" "Oh, yeah, I got that." It's like when you were in the Scouts, and you got the wee merit badges. "Do you have an accountable care organization?" "Got one of them, I get 3 of them." "Do you have a telehealth program?" "Yes, I do." And then you ask them, what percent of your patients get that on a routine basis? And the answer is the square root of 0. And this is just stuff to show the board. And I think we've got to be serious about innovation at scale. So let me just say in closing, I think that regardless of who's running the country, and we now know who it is, it's Mr. Trump, the pressure on public payment is going to continue. Private payers are not going to tolerate cost shifting willingly. The exchanges are going to morph, I think, with the repeal and replace legislation. Medicare Advantage is going to be here. Managed Medicaid is going to be here. And really going forward, the consumer is going to play a bigger role, certainly in a Republican administration, and it was doing it even in a Democratic one. In the long run, there's 3 payment segments: Managed Medicaid, high deductible health care, and Medicare Advantage. And I think regardless of your politics, those are the ones playing out. And the real punchline is you've got to redesign the delivery system for higher performance. I think there are 3 futures, and we've eliminated, at least in the short run, one of them, which is the dumb price control one. We're not going to do that in the short run. The question is, are we going to preserve as much as we can of the positivity, I think, that came out of what I call the Berwickian nirvana, at the same time as making it more market-focused for this new administration, who clearly view that they have a mandate to change healthcare and certainly to deal with Obamacare. So that's really the challenge going forward. I just hope we maintain and expand coverage, that we fix the financial gotchas so that at least it's fair and transparent to consumers, that when we consolidate, we do it for value, not economic power, that we innovate at scale, we improve the patient and provider experience. And I think we can harness the new science in doing that, both medical science and information technologies. So I would encourage you to be leaders, not followers for the future. And, I think for you all in your world, we've got to recognize there are fewer, more powerful decision makers. There's some are going to go alone. The integration across the continuum of care is going to be profound, and present new challenges. Value is not going away, and the focus on value, both price and unit cost, as well as utilization, is going to trickle down to everyone in the food chain. And I think what you can add value in two ways. One is being agents of clinical redesign, not just working harder or cutting prices, but really transforming care delivery, and also taking out waste motion between the administrative overhead of your transactions and the supply chain. And I know you're all professional about that, and we'll go after that work diligently. So I hope that's helpful, Dennis, and let me stop there. I know we're close to time, but I can stay on for to answer any questions you may have.
Oh, Ian, that was just great. That was just great, and you covered a lot of material for us in a short period of time, and much appreciated, really, especially being able to put perspective on it after just a couple of days after the election, or even less than a couple of days. A couple of questions, Ian, real quick.
Yeah.
One of our attendees on the webinar wanted to know if you think that it is likely that the industry will lose the 340B pharmacy status as a result of some of the changes from the election in a new Trump administration.
I wish I had that clear a crystal ball. I think the big uncertainty will be reconciling, and I have no knowledge of this, and I wouldn't. This did not come up in the call I was on with my friends at Levitt Partners, so I'm making this up so that don't impute any knowledge here. I think the tension is this. Mr. Trump himself, I think, pointed to purchasing power of government being a tool that he might utilize. Now, whether that translates into a serious policy proposal that could get through the Congress is another issue. What I would say, though, is that he and they, the Congress, have to deal with this issue. It is the number one issue when you talk to self-insured employers. Drug costs are the number one issue, and partly it's a result of 340B and the consequences of that in terms of cost shifting on pricing to them. So specialty pharma, number one issue. You look at the American Hospital Association did a survey, pharmacy costs 38% increase per admission over the last couple of years. So, this is one thing that the new administration is going to have to deal with. And the market, quote unquote, won't solve that problem, because what the market is clearly doing is using its monopoly power to drive up prices. So I think I think the whole area of drug pricing, including 340B, is a hot potato. That's now been passed on to the Trump administration.
Good. Ian, one more question, and then we'll conclude. One of our attendees here says, as a supplier, in your opinion, what can we do, suppliers, to prepare for the changes and trends that you're talking about?
Well, yeah, no, I think that's absolutely right. I mean, it's trite, Dennis, but I think is listen to your customer, because they are going to be processing, suppliers who are selling into, I'm thinking about my clients who are typically often large hospital-based systems, as well as the people who are paying the bill and some of the insurers. But I think, if I think about the 20 hospital board retreats I've done in the last few months, I think you need to be close to those CEOs and C-suite executives as they process the changes I described here. What I would say is that they're concerned about where's the money coming from. If you're changing the Affordable Care Act, what does that mean for Medicare payments, Medicaid payments, private sector payments over time? So they're going to be under duress, and I think you need to be very close to them. The other thing I think you need to do is monitor this policy set of changes to try and read the tea leaves in terms of, is there more money in the system or less money in the system? I just close by saying, Obamacare, for all its ills, raised $1 trillion worth of new revenue over a decade, right? That was paid for through taxes and givebacks. So some of it's not necessarily a net benefit for the health system, but some of it was a net benefit for the health system. And if that trillion goes away, is it going to be replaced by other private sector sources? So I just think this intensifies the theme of my talk, which is the need for value, just intensifies in terms of the pressures on the system.
Ian, again, I want to thank you. The one thing we can be certain is that things are always, to a certain degree, uncertain, and we'll see how this new administration pans out, and maybe we'll reach out back to you and see for your perception on how things are changing after the first of the year. But I want to thank you, Ian, for being part of the SMITU's webinar here and for repeating this. I want to remind all of our listeners that they'll receive a survey, and we appreciate if you can fill that out. And with that, we've reached the conclusion of our webinar. So again, thank you all. Thank you, Ian. And with that, we'll adjourn. Thanks much.
Thanks so much. Bye-bye.